So the Enhanced Recovery Programme was created by a group at the Department of Health to promote best practice. It came from a group of clinicians a few years ago getting together and deciding there was lots of evidence for improved ways of looking after patients, undergoing major surgery predominantly. And these clinicians went to the Department of Health and said, we should create a programme to promote best practice. This is all about improving patients' experience, improving their standards of care, getting patients better, quicker. Those patients having cancer operations, major joint operations, having gynecology operations like hysterectomies and major urological operations like prostatectomies. These patients, we know there's good international evidence that shows that they can be looked after in a much better way. It puts them more in charge of what's being done to them, and they recover sooner, they get back to normal as quickly as possible. And it wasn't being done across the UK in any kind of a uniform way.
It's a philosophy of care which is all about having a patient as a partner and indeed using the best techniques so they can speed through their recovery and get well faster after the operation.
Enhanced recovery is a good way for us delivering quality care to our patients, so they get their surgery in a timely manner, they're well prepared for it, and we get them back to what is normal for them as soon as possible.
For years we've had a very paternalistic approach in medicine. The belief has been that people want to be in hospital, and we haven't really challenged that and questioned that, and we have treated people as patients. You're a patient, you're here for us to do what we do to you, and then when we say so you can go home. And we've gradually changed that as society's matured and been slightly more demanding of our professions. Of course, along the way, we've developed all these super resistant bugs like MRSA and Clostridium difficile, and we've had to try different strategies to remove them from the hospital. One of the things is trying to keep people out of hospital. The longer you're in hospital, the longer your potential to develop resistant bugs is, and the more likely you are to succumb yourself. So over the last few years we've made major inroads into the sheer number of patients who've developed resistant bugs. The other thing is that if you're in hospital you tend not to be terribly mobile. People who are at home, who have to get themselves up to go to the loo, who have to get up to go and get themselves a cup of tea and make something to eat, are, without realising it, performing their own physiotherapy. Whereas if you're in a hospital bed, the chances are somebody brings you the cup of tea, somebody brings you your food. So by actively promoting the idea of people getting up and looking after themselves, a lot of the other extraneous activities that are performed in hospital are removed from the equation. For example, where colorectal wards have introduced a dining area that for many years were taken out of hospital wards, with a fridge in it where patients can go and help themselves to nutritious drinks, but of course they have to get to the dining area, so there's a walk involved. The alternative would be that they would get their food provided at the bed space, but a physio would have to come along and get them up and take them for a walk independently. So right from the beginning, when they're referred by a GP or when they present at an A&E department or to a physiotherapist with a complaint, could be one of many, they're informed right from the beginning about the possibilities, about what might potentially happen with them and to them as they pass through the system. Following on from that, they feel much more a part of the process, and we try to remove the done to and replace it done with, the concept where the patient understands what the problem is, understands what the potential treatments might be, and gets to make a choice in those treatments. Following on from that, if the patient does opt for major surgery, they play a more proactive role in keeping themselves properly hydrated, properly nourished, building up to the operation. They get themselves more active, they stop smoking, they reduce or stop drinking alcohol in the lead up, so they're in a much healthier condition prior to the operation. And then immediately the operation is completed, they're engaged in mobilising, eating and drinking, taking control of their pain relief, such that they're fitter sooner, they're ready to go home more quickly.
Cheerio, Margaret, all the best.
Well, benefits to the patient is, first thing, we can use our resources better. So patients are in shorter, which means the cost to the trust is less, we can do more patients through the same ward than we could do 5 years ago. For example, 5 years ago we used to have 2 wards. Now we have 1 ward, which we struggle to keep it full because patients go home that quicker.
They feel more ready for surgery with the preloads that they get, and then afterwards I think the care that they get, because there's a lot of additional care they get, mobilizing, and the fact that they can go home early and be surrounded by their families and be comfortable having the food and drink and the environment that they need post-operatively. And it has been shown that the infection rates for these patients are reduced because they're out of the hospital environment sooner.
When we first started Enhanced Recovery with hip and knee patients, what we found was that the patients were quite nervous. They'd been told by friends and they'd been led to believe by many healthcare professionals that they'd probably still be in bed after 4 or 5 days. And we were saying to them, no, you're going to get up the same day of your operation or within 24 hours of your operation. So they're rightly quite nervous, and admittedly so were many of the healthcare professionals when we started to push this. But within a very short time, within a matter of weeks, the patients who were going through were all being mobilised very quickly. So patients being admitted to the ward were expecting the same thing. And in fact, when we introduced a hip pathway in one of our wards, we found that the patients who weren't on that pathway, who'd had knee replacements, were saying, why can't we get up the same as those patients? They had their operation after me and I'm still waiting. So it's driven the programme on because the patients have actually said, do you know what, I'd like to be treated like that. I want to be up and about and I want to go and have my dinner sitting at a table, not propped up in bed.
They come to pre-assessment, depending on what speciality they are, alters who they see. But usually, especially with the gynaecology patients, they'll come and they'll see one of the nurses. We spend about an hour with the patient, so taking their history, their bloods, ECGs, and also talking them through the enhanced recovery process.
The pre-assessment clinics have been developed over the last few years to highlight any issues that individual patients have rolling up to their operation. That might be psychological issues that the patient has themselves, or more specifically physical health problems. So any patient who has comorbidities, other health issues, whether it be breathing problems such as asthma or chronic obstructive pulmonary disease, COPD, diabetes, hypertension, thyroid disease, all of these conditions and more need to be highlighted at the pre-assessment clinic so that the staff can check that they're optimally controlled or if anything can be improved.
We make sure that the patient is very well counselled about the underlying condition and the nature of the treatment planned. So when they come up to the pre-assessment clinic, we're able to have a conversation that is specifically about the day-to-day of what to expect during the time of their operation, and also to talk about the technical details of the operation so that they can give properly informed consent at that time.
For gynaecology, I think the average for an inpatient sort of hysterectomy was usually between sort of 3 and 5 days, and now if they're doing it vaginally, they're only in overnight, and maybe abdominally they might be in for 2 nights after surgery. So it's significantly reduced the patient's length of time in hospital and improved their journey and the process significantly.
Colorectal patients is the biggest win, and they used to stay in an average of 10 to 14 days. Our average length of stay for major colorectal patients is now 5 days.
Patients seem to really appreciate the Enhanced Recovery Programme because it is getting them back to their normal life as quickly as possible.
If you come out here, can I get you to walk towards the brown door and then back to me?
They seem quite surprised sometimes to begin with as to how quickly things are going to move, but they seem to like that.
The feedback I've received since Enhanced Recovery has been introduced is the fact that their stay in hospital is actually a lot shorter, and obviously patients respond better when they're actually at home.
The feedback from patients who've been through the system, they felt it a real boon to be able to get home earlier, get back to normal more quickly, be allowed to relax in their own home, sleep in their own bed, eat their own food when and where they want to. Generally speaking, most people have been very satisfied with the level of pain relief. Some patients who've had previous operations not under the programme have been able to really contrast how much nicer it's been this time round, because all of their needs have been taken into account in a much more uniform way than previously. The other side of the feedback is that they've felt informed, and there's always been someone to answer their questions. There's lots of paperwork available, and they're directed to online resources where they can look for information, so they felt better informed about the process.